Hi, I'm Charles Kahi. I'm an associate professor of clinical medicine at Indiana University School of Medicine and the chief of gastroenterology at the Raudebusch VA Medical Center in Indianapolis, Indiana. Our research presentation is minimal proximal colon serrated polyp detection rates in average risk males and females. Despite the evidence supporting its effectiveness, colonoscopy affords imperfect protection against colorectal cancer, and some patients are diagnosed early after colonoscopy with so-called interval cancers. The reasons for these interval cancers are varied. However, it is clear that proximal serrated colon polyps play a significant role in the pathogenesis of interval colorectal cancers. The effectiveness of colonoscopy as a screening modality depends on the quality of its performance, and this is currently best measured by the adenoma detection rate, which has been validated as a strong predictor of the risk of colorectal cancer after colonoscopy. However, given the growing importance of the serrated pathway in colorectal neoplasia in general and in the risk of interval cancer in particular, it is clear that defining the minimum proximal colon serrated polyp detection rate is also important. Recommended adenoma detection rates in males are 25% as a minimum and 15% in females. Corresponding proximal serrated polyp detection rates have not been defined, and this was the main aim of our study. The study received IRB approval at Indiana University Medical Center. It was a retrospective study of screening colonoscopies performed at IU Medical Center and an associated ambulatory surgery center between January 1st, 2000 and December 31, 2009. Colonoscopies performed by 15 attending gastroenterologists were included in the study. Only screening colonoscopies were included, and procedures which were done for any other indication, including surveillance and for diagnostic purposes, were excluded. We defined the proximal colon as colon located proximal to the splenic flexure, and serrated polyps included hyperplastic polyps, serrated adenoma polyps, traditional serrated adenomas. Data from each colonoscopy were evaluated to calculate endoscopist level adenoma detection rate and proximal serrated polyp detection rates. The variances between adenoma, proximal adenoma, and proximal serrated polyp detection rates were calculated, and we determined Pearson correlation coefficients between adenoma detection and proximal serrated colon polyp detection. And finally, we performed linear regression to study the relationship between adenoma detection and proximal serrated colon polyp detection to determine serrated polyp detection rates corresponding to 25% ADRs in males and 15% ADRs in females, respectively. Moving on to the main results. 6,681 colonoscopies were performed by the 15 gastroenterologists. Mean patient age was 59 years, and 49% were male. Detection rates were as follows. Adenoma detection rate on average was 38% and ranged from 17 to 47%. For proximal adenomas, this was 28%, ranging from 13% to 36%. And for proximal serrated polyps, it was 13% on average and ranged from 1% to 18%. There was no significant difference between the variances of the three detection rates. There was, however, a significant correlation between adenoma detection rate and proximal serrated polyp detection rate for males and for females. Adenoma detection rates of 25% for males and 15% for females both corresponded to a proximal serrated polyp detection rate of 4.5%. This is shown on the following graph, showing the correlation between adenoma detection rate between adenoma detection rates and proximal serrated polyp detection rates for males, and on the following slide for females. In conclusion, in this large cohort of patients who underwent screening colonoscopy, there was a strong correlation between adenoma detection rate and proximal serrated polyp detection rate. And we suggest a minimum detection rate of 5% for proximal serrated colon polyps for males and females.